Welcome to LIVE3. Our first case in this live is a 71-year-old male patient diagnosed to have chronic pancreatitis, complicated by obstructive jaundice and fever 3 months ago. CT scan of the abdomen showed CBD dilatation of 16 millimeter. The MPD is dilated, measuring 8 millimeter with 7 millimeter stone at the level of the papilla. There was no evidence of pancreatic mass and no evidence of CBD stones. Also, we performed an EUS which showed changes suggestive of chronic pancreatitis, enlarged pancreatic head and ampulla, dilated MPD measuring the 7 millimeter and stone just above the papilla, measuring 6 millimeter. This is the stone. And also the CBD appears dilated, measuring 16 millimeter. So we just wanted to manage the acute cholangitis. We did an ERCP. It showed ampullary enlargement. We took biopsies and it was negative for malignancy. The CBD also, as shown previously, it measured 15 millimeter with distal stenosis, 1.5 centimeter in length. So we just put a plastic biliary stent, 9 centimeter, 10 French. MRCP was done on 4/9/2023. It showed also persistent CBD dilatation 17 millimeter, MPD dilated measuring 8 millimeter. Also, there was no evidence of a pancreatic mass, and this time there was no evidence of CBD or MPD stones. So the plan now is to do ERCP to extract the pancreatic stone. We will look for pancreatic stone if it's still there or not, and to evaluate the CBD structure for possible biopsies. Done by Dr. Horst Niehaus and Dr. Ammar Ghazali. We will, just before we start with this case, we will move to the last case that was about the colonic polyp in the right colon with Dr. Pradeep to see just the final result.
Hi, welcome back, guys. I don't know, maybe it's 2 hours or 3 hours down the line. We managed to achieve this by a combination of underwater resection, a little bit of EMR, and ESD. Well, I won't say ESD, but what I call it knife-assisted resection. So we used the knife just to cut the edges so that we could get a snare in. You can see severe fibrosis in all these places. It just shows a little bit of touching with a snare, what it can do to the base. So now we are confident that everything is off, but it's best to avoid this kind of situation. It's very difficult colon, very difficult access, and severely scarred polyp in right colon. So nothing about this is straightforward. Location is not straightforward, access is not straightforward, and polyp is not straightforward. So thankfully, it's all done, but in future, it's best to avoid. The learning from today of my 4 hours effort is only one. If you are treating a polyp and access is unstable, please do not proceed. Never proceed resecting a large polyp with unstable access. Abort. Stop the procedure, come back next day, because otherwise it just creates a real mess for yourself and for the patient. But thankfully, Jar could put up with us for 3 hours, cancel all the other cases, and a combination of knife, underwater, and EMR, we managed to finish it. Thanks a lot.
Lots of coagulation.
Yes. And excellent support from Dr. Al-Kandari. Thank you very much.
Okay. So you already heard about the history of this patient. So he has no pain, but he was jaundiced before. Biliary plastic stent was implanted. So as we can see now, when you switch to the endoscopic image, the papilla is quite elevated, is bulging, and we already removed the biliary plastic stent that came out of this orifice here. So that means this is obviously the biliary orifice, and you may think the pancreatic orifice is probably around here. But when we change the position of the scope a little bit, we see this structure here, which looks like the normal papilla without sphincterotomy. So we don't know exactly if a fistulotomy was done or if it's a spontaneous fistula of the CBD. So this is unclear, because when a sphincterotomy, a biliary sphincterotomy, would have been done here from this papilla, then you should see the cut and the open papillary roof here, but here's healthy tissue. So this is a little bit unclear. So in any case, this is a fistula between the distal part of the CBD and the papilla. So when you're dealing with patients with chronic calcifying pancreatitis, before starting ERCP, I always recommend to do just a plain X-ray to see if there are any calcifications, and yes, they are. So when you see it, when you show the fluoroscopic image, you see calcifications alongside or within ductals. So they show the structure of the dorsal and ventral part of the ducts. And CT scan showed also several calcifications, whereas MRCP did not, but MRCP is not very accurate in terms of stones. So now we will see what happens. I try to get the tip of the sphincterotome firstly in the direction of the pancreas. So that means I'm cannulating. The position is a little bit difficult from here. Let me see. I try to. Can you just hold it and rotate it a little bit? So, okay, this is better. Because it's distally located. So I try to get it in a 2 o'clock position. I cannot come closer. So I suck to decompress. So I lift. You can carefully try to probe. Push the wire in. Resistance, okay. Pull the wire back. So according to MRCP, the stone is very close to the papilla. This may hinder the insertion. You can try again. Resistance? Yes. Okay. Then at this stage, we cannot easily cannulate, but the tip is inside. Now we are inside the duct, I think. So this is now the time that, yeah? No. So can we inject, can you turn so that I can see the X-ray better,
Yeah.
the screen?
Let's turn it this
So
way.
inject a little bit contrast. Yeah. Resistance? Yes. Stop. Okay, then we change again. So when the stone is just at the level of the papilla, we may, even with injection, we may not get any contrast inside. So I change the position again. Resistance?
No, I'm going.
Huh?
I'm going with some resistance.
Can you even turn it more
No,
so
you
I
have to
can
turn
hardly
back.
see the screen?
مقفلين هيدي
Okay. Then
locked.
inject a little bit contrast. No. But as you can see, just above the tip of the sphincterotome, we see these calcifications.
ما بتبرم بعد الشاشة.
And I'm quite
قصدي
convinced.
عن.
Yeah, now I'm inside somewhere.
No.
This should be the duct now.
بس هديك لا.
Yeah. Okay. Now, okay, I changed the position. And now, no. So at this stage, we are undoubtedly in the, very likely in the pancreatic duct. Now he feels resistance, then we shouldn't push even more, but we should inject, we have to see the anatomy. By the way, it's better also to use an angulated wire at this stage. So inject a little bit contrast.
Injecting.
Let me see. Where we are. Now it's just behind, stop. We are just behind the scope. Can you try to advance the wire again?
You might be injecting the fistula.
Stop. Maybe. Yeah, maybe just. Yeah, of course. Yes. Or we are in the. Okay, can you hold it? Yeah, in the CBD, huh?
Why are you not doing now pancreatic sphincterotomy?
Yeah, but I'm not sure that I'm in the pancreatic duct.
The guide wire and the CVD.
No. Advance the wire. Yeah.
No.
Do I push?
I'm not seeing.
We will move to another case in our LIVE3, a 38-year-old male patient with morbid obesity, past medical history, hypertension, diabetes, and asthma. In 2009, his weight was 250 kilograms with BMI 73. On 2014, he underwent gastric sleeve where he lost around 90 kilograms. After 1 year, he started to regain weight, reaching 180 kilograms. 3 years later, he underwent mini bypass surgery and only lost 15 kilograms. He took several medications for weight loss, including Trulicity, Saxenda, Ozempic, till he reached 105 kilograms. He was infected with COVID-19. Doctors prescribed for him steroids, cortisone, treatment several times, so he regained weight and currently 145 kilograms with BMI of 42. So decision was made to do endoscopic sleeve gastrectomy with a reduction of the anastomosis side and the stomach size by Dr. Jeffrey and Dr. Tariq Saleh.
Hello, everyone. I'm very happy to be with you. I am with Tarek and all the team. Tarek, which is a good friend with a very huge experience in
Thank you so much.
in endoscopic bariatric procedure and metabolic procedure. You know that we try to say endoscopic bariatric and metabolic procedure because we know that we treat the liver disease, the diabetes disease, and the cardiovascular disease when we try to reduce the weight of the patient. So we have to reduce the pouch of this bypass, of this patient treated by bypass previously. And we know that there is 3 to 4 different methods. We discussed about that with Tarek previously. The first one, and certainly the most expensive one, it is the overstitch. The second one it is to put a clip of Esco, which is a German firm, develop a new system of clip to put on the anastomosis to close the junction between the gastric pouch and the jejunal loops. Sometimes some Brazilian colleagues try to do only APC, and we perform always before the procedure of suture. The APC of the anastomosis, like you can see maybe here.
It's a tight anastomosis, yeah.
Yes, and because it was not a very large anastomosis, so we decided to do the APC before we take the line and the video with you. And the last one is maybe to perform mucosectomy or to resect and dissect the anastomosis to induce fibrosis and the reduction of the opening. So here we decide to perform the overstitch procedure and the heater, which could be performed on different way. Our colleague Christopher Thompson in US described a lot of different techniques. The best one, the most aesthetic one, is certainly to perform points on each circular line of the anastomosis, and then to cinch and to close the anastomosis on a balloon, which is insufflated at 8 millimeters. So it is the most aesthetic one way to do that. But sometimes it is not very easy to do, or anatomically it is not possible to do. And it is the case here. It is impossible to do this kind of procedure. And we decide with Tarek to only try to close with 3 different points and 1 suture the anastomosis. Then to perform another line of points here, because there is a huge and large pouch above, and to perform maybe a suture in U here. Yeah. So we will start from the anastomosis, and the needle was already loaded with the wire. And we use the helix, which is here, to catch the mucosa, and then to do the first point. So, go. So we will catch the first. Okay, it is good. You have to tract the mucosa and the muscle, if possible, here. Avoid to take too much of material inside. Okay, you can retrieve the system. Okay, perfect. So we do the first point. Tarek, if you want, you can describe.
Fine. We will do the second one and
the second one
laterally.
Yes, here. Yeah. So before to perform the second one, you have to have a free wire. The principle is to work very, not very close from the target. You know, it is different from dissection, resection, mucosectomy, and so on. You have to work very far from the target.
We have a cross. Maybe on peut, ici, il y a une loupe là. On peut le reprendre pour décrosser.
Okay. Alors, hop, here we have a cross. So. Alors, attends, hop.
Voilà, c'est parfait.
C'est bon là?
Ouais.
Allez. Okay, so we. Okay. So.
Non, regarde ce que tu fais. Ferme-le.
Okay. So we just have the loop.
Yeah. Ok. Ouvre-la vide. Laisse le tissu.
Attends. I have to catch the.
Ouais, exact. Voilà, c'est bon.
Yes.
Voilà, maintenant, sors-le, hein. Pousse-le.
Yes, we have to push.
And voilà.
Just you have to be on the well positioned just to...
هلا وقفت إيه؟
Okay.
Excellent, excellent.
So now it is good.
Yeah.
So go. Okay.
Excellent, hein?
You have to perform three turns with the helix. Don't want to take too much material inside. Okay. Okay, perfect. The second point is now
Excellent.
performed.
Yeah.
And we will finish for the anastomosis with the third and last point. So,
Tu peux entrer à l'intérieur, même sans helix, ouais. S'il y a de la place. Ouais, il faut mieux prendre avec l'helix. Excellent.
okay. The problem is that most of the time we need space with
Yeah.
this kind of material and system, and
Yeah,
it is not very
easy, yeah.
okay.
Yes, great.
Now we're live.
Okay. So this is very interesting. As you have seen, I said we are in a duct when we cannulated the papilla, but it was not the pancreatic duct, but it was the distal part of the bile duct. So the patient had this fistula, as I said, and then I could cannulate the common bile duct, and I did a large sphincterotomy, so I opened the blind sac. That means the part of the CBD between the fistula and the true papilla. Now it's fully open, as you can see here, and I even extended to the roof, to the papillary roof. We injected so that wire is now in the CBD, and we opacified the common bile duct, which showed bile duct stones, or at least a lot of sludge. And because MRCP showed a stenosis of the distal part of the CBD, we will now and there are probably stones inside. We will now combine sphincterotomy with large balloon dilatation. And for this purpose, we prepare the CRE balloon from 12 to 50 millimeter in diameter.
This is the one that doesn't have a wire, no.
This doesn't have a wire.
No.
Okay.
اللي بياخد
You
wire.
can give me, we can try in between. Before you, maybe we can get it inside.
Alongside the wire?
No.
This is
for
without
short
the wire. Yeah.
So maybe they don't have the wire guided. No, I'm fine.
You can lock the wire since it's there.
Yeah, you're right. So I lock the wire. So I can lock the wire because it's short wire technology. So we try to get it alongside without guide. I don't know if it works, but you can still try to find the wire guided balloon. So I try to get it in the axis of the CBD. Yes.
Perfect.
So we saved some money, huh?
Yeah.
Good for the unit. So we are ready with the manometer. So we inflate the balloon. And according to all randomized controlled trials, the combination of mid-size sphincterotomy plus large balloon dilatation decreases the need for mechanical lithotripsy So it's much, yeah, 12 millimeter. 12 is enough.
Okay, I'm at 12.
Okay, we'll see if there is any. Is it mixed with some contrast? Okay. Okay, there is still a small waist just below the endoscope. We wait for a second. So it facilitates stone extraction, even if you have multiple stones or stone fragments after mechanical. It's much easier to remove these without increasing the risk. So there is no increased risk of post-ERCP pancreatitis or bleeding. Okay, now the waist disappeared. Now deflate and suck to decompress. Okay, and prepare already the stone extraction balloon. Yeah, but firstly, let's remove. This can be pull.
أي size هيدا؟
No. Suck the balloon. Okay.
هذا ما حيكفي. You want bigger than a 912 for the extraction balloon, right? If we have bigger,
but
P12,
if
15.
it's just available.
Let me see. Oh, okay, good. يلا.
Okay.
ما قلت 912 فكرت. إيه.
So.
Okay, perfect.
So I always watch the wire that it doesn't migrate. Okay. Oh, we see the wire. So now the dilatation balloon is out, and we insert the stone extraction balloon catheter. Now we have a nice opening. Should be very easy to cannulate now the CBD. We see a lot of bile coming.
Thank you.
So I think this is the main problem for the patient, not his chronic pancreatitis, because as we have already heard, the patient has no pain, but we will finally see what happens now if we still have a stricture. Just in case we have an ongoing stricture, still persistent stricture, then I would place a fully covered metal stent in case of, because this stricture is related to chronic pancreatitis. His histopathology or cytology was negative.
What is your thought on the difference between a fully covered metal stent versus multiple plastic stents for benign strictures?
Yeah, well, the clinical results, we participated in the prospective trial with more than 130 patients with the group of the Devier. Long-term outcome is excellent. So 80% of the patients treated with metal stents benefited even after removal of the metal stent. You can achieve the same with plastic stents. You can pull, but with multiple plastic stents. But it's much more convenient. So you place it, leave it 11 months in place, and remove it. Whereas with the plastic stents, you have to repeat it repeatedly. You have to exchange the stents, and it's much easier to implant. Therefore, I think also the overall costs are not higher because it's a single procedure.
Yes.
So we will see. Now you can inflate the balloon.
Inflating.
Inject. So there is probably
stricture.
There is still a stricture here. Yeah. Deflate. Okay, but a small, very short stricture. Some stone came out, as you can see, but now I can easily. Maybe the stone was impacted here.
بس hold on. ليه مي هذا؟
Yeah, exactly.
لا انفخها بالأول.
Very interesting case.
هلا.
Yes. So inflate. And now inject again.
It's not inflated.
No.
We're going to move to
okay, we move to another room.
Mhm.
Okay.
Okay.
Okay. Just okay, more stones coming.
Okay, we're going to go to room
Okay.
2 for a
Okay.
while.
Okay.
Okay.
Good. Now look here.
There we go.
Can you hold it? This is always the problem.
Yeah,
Can you
here.
hold it, please?
Yes.
Big.
Try to perform a line. Okay. Here with Tarek, we decide to perform a second line, and we will do a third suture in the pouch, because it is a very large pouch of bypass. So we don't know in the literature if performing and associating the suture of the anastomosis and of the pouch is always mandatory. It is a question which, and there is no response in the literature at this date. There is no randomized control study now. And
Voilà, excellent.
okay.
C'est bon.
And it is a real problem at this date. And the quality of the literature is poor, and we need, and I hope that we will do in the future, some randomized control study on this subject, just to have information. So you have to put the cincture and the tip, the white tip of the cincture, close from the last point you perform. And we will just... Can you just fix here the catheter?
Are you taking care of this?
Yes. I take it. And you see that our assistant do a fixed point with the catheter, and now I am just
Excellent. Tu peux tirer.
pull the guide wire slowly. You have to avoid to cut the wire during this last step. And you can see that you close slowly.
Ah ouais.
Stay here. Okay, perfect. Push a little the catheter and stay fixed. Yes. Okay, so now you can cut. So we will cut. Yes, you can cut the wire. Okay. And now it is finished for the second suture. So you will have an endoscopic view of what we have doing.
The first row, this is first row.
The first row is here. You saw that it is like a ring.
Yeah.
We have created here,
Yeah.
just above the anastomosis. The anastomosis is here, in deep of this new cavity we create.
Yeah.
The second line is here, and we will perform
Another row here in this
another row here.
side. Yeah.
Okay, so if you want, you can go in another room, and we will, some water, please, just for the, yes. And we will show you the last suture pattern. Thank you.
But look here.
Much better.
No. Okay, inflate. Okay.
Oh, we're live.
Okay, now it's very easy. We are live?
Yes.
Okay. So we removed several stones, and they were impacted in the papilla. And now, as you can see here, we have a nice opening This was, so the stricture was really related to impacted stones. Now we have a nice opening, and if you inflate again, okay, it's now inflate. We don't inject at this stage because I plan to do cholangioscopy. No, it's not inflated. Yes, please. Okay, you see, I can easily push it in and out so there is no more stenosis. But of course, we already prepared IMAX because we expected a pancreatic stone. This is a new cholangioscope from Microtech, and I think it's justified in this particular case to do cholangioscopy to exclude remaining stones firstly, and also to visualize the site of the previous stenosis. So you may switch to now. Yeah, when you have time, we can show how we insert it. So advance the wire. Advance the wire. So get the IMAX ready. Push, push, push. So we will insert IMAX over the wire. Of course, you can also do freehand cannulation. So when you switch on the lights here in the room, then we can show the device. Push, 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 push. So this is quite remarkable. There are two different devices, and I'm with a smaller, more flexible 8 French, 1.3 millimeter channel, but here we already prepared the one with a 2.0 millimeter channel. And this, I think, is advantageous for therapeutic interventions as well as for taking biopsies, which, as you know, is difficult with the 1.3 millimeter channel. So I show you how it works.
And this is a 10 French catheter?
It's a 10 French catheter. We, as you can see, we inserted over wire. The tip can be maneuvered in 4 directions, quite similar to spyglass. And also it has an excellent, as you will see, image technology with a CMOS chip and LED at the tip of the instrument. So this should be open. There's resistance. Take it, either take it off, insert. So then it comes out. Now you can reinsert the valve. Put it. Okay, go ahead. So it's like a big probe, very easy to maneuver. So pull a little bit on the wire. So I unlock the wire. So, and now I will show you, it will not be attached to the duodenoscope, but as you can see, I already have a pull. You have to pull on the wire a little bit. Okay. Elevator's open, and now you can nicely see that I introduce it in the CBD. As we do with all stiff devices, stay very close to the papilla, carefully probing. Tip is inserting. Then I advance the duodenoscope to get into the axis of the CBD. Slight resistance here. Therefore, it's good that we elevate it. Okay. Let me see the position of the wire. The wire is too far inside. Okay. Okay, so now we connect.
Pull the wire back.
Okay. Yes, now we are inside. Now you can lock it here on my belt.
Yeah, let him.
So. Looks very elegant, huh? So I'm maneuvering it here. This is the valve, so it's still on the wire. I lock the wire, and here is the the connection for suction. So I could also suck to decompress the duct. Can you close the valve, please, for me? Okay, so now we switch to the... So do you see the
The
image?
water pedal? Is
And
there
now I need the water pump.
the water pump, or is it?
Okay. The water pump doesn't work yet. Now it should come, huh? Yes. So,
Do you feel it coming?
okay. Now it's coming. And as you can see, as I predict, there's still some sludge inside. So, and at this stage, when you want to manipulate, you have to remove the wire, because otherwise, if it's still on the wire, yeah, take it out, you cannot maneuver the tip. So I think you can appreciate that there are still remaining stones here. And now I'm approaching, as you can see, I'm approaching here on the right side.
Are they able to see the cholangioscopy image?
Do you have the cholangioscopic image? Ah.
Can you
Okay.
Can you bring the camera over here?
You should connect.
Now we're seeing it.
Huh? Yeah, please.
It's very clear.
Yeah, okay.
You're up in the right duct, it looks like now.
Okay. So we are here in the right hepatic duct, and as you can see, there are no more stones, and you can appreciate the excellent view, very good resolution, and as you can imagine, also for diagnostic purposes, we can evaluate the vascular structure very nicely, and it's a bright image, an excellent imaging control, and I'm carefully slow it back, and as you can see, there is no, we removed the wire, but you can easily also do targeted cannulation. So I pull it slowly back. And now we're approaching the hilum.
Can we insert biopsy also?
Yeah, you have a 2.0 millimeter working channel. So we can insert biopsy forceps, lithotripsy probes. So this is now the left hepatic. Yeah, I think we are still at the hilum.
Let's see on fluoro.
No, this and has already. We can enter. We can enter. I think this is the first demonstration in the Middle East of this device. So, and as you can see, I can easily manipulate. So bile is coming. No, this is the, I think this is the left hepatic. This is the left hepatic duct.
Let's see it.
This is no longer the cystic duct.
Is that a fresh image up there?
Yes.
Ah, yeah, left hepatic.
Yes.
Okay, great.
So it's also free. And as you can imagine, this is very helpful also for targeted cannulation. If you have difficult strictures, you insert the wire and you cannulate under direct vision. Now we're going back. So as I said, we can also flush, we can suck to get rid of the mucus. This is the confluence between the left and right. Normal epithelium. Now we are going slowly back to see there is no need. So these changes here are due. And it's important also, it's so nice, everybody is fascinated, but it's important always to keep the image of the cholangioscopy, of the duodenoscopy under control, because otherwise you can easily use your access. Okay. Now here's getting a little bit more narrow. So I change the position. We have now a nice view of the mid portion of the CBD. And now, yeah.
You're very low. You can
and
see
we
the
are
light.
already close to the papilla. You see the light? So we can even evaluate the very distal part of the CBD is here. Yeah. So we are very close to the papilla, and we don't see any irregular vessels. So this is already the site. As you can see on the duodenoscopic image, we see the light at the papilla. So we can precisely evaluate the distal part of the CBD. There is nothing. So this was related by an incomplete, so there's no sphincterotomy. Now we did sphincterotomy, balloon dilatation. We have some remaining debris. But I suggest I will place a double pigtail stent just to be on the safe side, or we can even.
My feeling is that that duct it seems low for bifurcation. Yeah, that's what I'm wondering. If that's over there,
we can inject this maybe. Yeah, we can inject contrast to see. Then this would be a very much dilated cystic duct, but could well be.
Exactly.
So
small stone there,
yeah.
That's fine.
Okay, we can inject contrast. There could be that. This is the cystic duct. Yeah. Okay. So now we inject contrast. Eight. Okay, inject. 7 is fine. Okay, inject. Yeah, more. So we inject more contrast. Then we will see where we are. Oh, this is a lot of air.
Yeah. Take the air.
Okay. Yeah. Now it fills very slowly.
Not sure where this is going.
But otherwise, you can give me also the wire again. Okay. Yeah.
Mm-hmm.
Please give me. Okay, now it fills. Okay. Go to the head of the patient.
They're gonna go for 2 minutes over to the other room, and then they'll come back to us.
Okay.
Okay. Go ahead. Okay.
Now, can you inject one more time contrast? I think I just saw the valves of the cystic duct. Then it's very far proximal.
Mm-hmm.
Yeah.
Do a fixed point. Okay, so welcome back, and we push a little, and stay fixed. We perform the last suture. Push. Stay. And you see that slowly, we are performing the last suture. Okay.
No. Push.
Okay.
C'est bon.
Okay, so you
Release.
can cut, release, and cut.
OK.
Okay. And you will have an excellent view of the result, of the final result. With the last line in terms of procedure, and the first when you go inside the poche. The second one here, and maybe we don't try to go, but it is always possible in the anastomosis here.
It's closed, practically closed.
So it is clearly a good result, and we hope that this patient will again lose some weight to improve his general status and metabolic status. So thank you.
Okay, we're live. We're live now.
Okay, so we are still, I think, in the cystic duct, but to be on the safe side, I would like to insert a guide wire. This is to see if this is just a very proximal entry and confluence of the cystic duct. Okay. And therefore, the option is that so we are here. So this is just to exclude that we have additional stones somewhere. So the guide wire is here, coming out. So, and as you can see, I can nicely maneuver the tip here. No, you are just
بتفرجينا هون بس please. تفرجينا هون بس.
As you can see, how easily I can manipulate the wire under direct vision. And when you now see on fluoroscopy,
There we go.
it's a gallbladder. Yeah? Can you see that on fluoroscopy?
Yes, we are.
Can they see fluoro?
I cannot hear you, unfortunately.
Can they see fluoroscopy?
Okay. So that means the wire is in the cystic duct and in the gallbladder now. That means we have a very large opening and confluence of the cystic duct. And now show the cholangioscopic image again.
It's showing.
So coming back to the junction of the cystic duct on the right and of the common bile duct, in the far distance of the common bile duct, you see the confluence. So it's as you can see how easily I can manipulate. Huh?
You want to show them where
Yes.
we are on fluoro now?
So we are now
now we're
far
up in
in
the
the
bile
right
duct.
hepatic duct.
Very nice.
And again, we are very much convinced that there are no more proximal stones. And now you can nicely see the exit to the right. It's a trifurcation. And just in case of a difficult cannulation of the left hepatic duct, only to show it, I manipulate here with my wheels. So this is just the niche here. Let me see.
Is it a small diverticulum or is it a...
No, no, no.
Oh, no, there
It's
it
a sharp
is.
angle.
Okay, it's just a sharp angle. There.
So now we are in the left. And as you can see, everything can be done, and this is the future. So everything can be done under direct vision.
Can we see fluoro? Just cannulating selectively the ducts.
Yeah, we
There
are
we
on
go,
the left
left
side.
duct.
It's a small,
Excellent. Nice.
probably a small. As you can see now, we are far inside the left hepatic duct. And this is the future. So you will see ERCP will be more and more replaced by direct visualization. Nobody could believe that colonography would be replaced by colonoscopy, small bowel imaging, enteroclysis now with enteroscopy and capsule. And this makes so much sense to do many procedures under direct vision. And in addition, we have much less radiation exposure. But again, keep it in mind when you do that, you cannot manipulate very well when the wire is far inside. Yeah? So take the wire back, because then the tip of the cholangioscope is, of course, fixed to the duct. Now I can manipulate. Now I have free manipulation here.
Yep.
Yeah, and look at the brightness also of the image. So we will see how many stones are left. Maybe due to the manipulation, maybe we don't need a stent anymore, because now we are close to the...
So I think they want to wrap up this live, so we can continue,
Okay.
but we'll
Okay,
we'll
thank you
sign
very
off.
much. Thank
Yeah.
you very much.
Okay, thank you.
Thank you very much.
So the next session will be about colonic polyps, EMR versus EST, will be presented by two doctors, Dr. Shayma El-Khawli and Dr. Muhammad Sharbini. So Dr. Shayma is the Associate Professor of Internal Medicine and Gastroenterology at Faculty of Medicine, Cairo University, as well as a consultant of gastroenterology and endoscopy in As-Salam International Hospital in Egypt. Dr. Muhammad Sharbini is a lecturer of internal medicine, gastroenterology, and hepatology unit at Cairo University, and a consultant of hepatogastroenterology and endoscopy at As-Salam International Hospital in Cairo. So, welcome.
مساء الخير. بنرحب بيكم. برحب بشيماء الخولي اختي وزميلتي، وانا محمد الشربيني. النهارده هنكلمكم على موضوع EMR versus ESD. في المقدمة طبعا احنا سعداء جدا جدا على تواجدنا للمرة الثالثة على التوالي في ليبانو لايف السادس الجميل، اللي كل سنة حاسين ان هو بيكبر، وكل سنة اكتر، وفي خبراء اكتر من كل حتة في العالم. سعداء جدا ان احنا من ضمن دايما المشاركين، وكنا لينا دور في المؤتمرات اللي فاتت. يمكن دي من ضمن الحالات الصعبة اللي اتعملت السنة اللي فاتت، كان ليجن ريكارنت وفايبروزس موجود في الريكتم، شلناه. كان برضو عندنا ليجن تاني صعب موجود في الاسندنج كولون، عملنا 2 ليجن من الاي اس دي السنه اللي فاتت. سعداء بالتجمع العظيم ده من السنه اللي فاتت، والسنه دي كمان اجمل واجمل. واللي احنا فرحانين بيه ان كل سنه الموضوع بيكبر، والليبانو لايف بقى احلى، يمكن على من اعلى المستويات العالميه والانترناشونال كونفرنسز وورك شوب، واعتقد شيماء توافقني في الراي ده. طيب, to go in short, we will talk about the endoscopic mucosal resection and what the difference between endoscopic mucosal resection and endoscopic submucosal resection. It's just differences in letter. No, we have two weapons. We can remove the lesion with snare or with the knife, so we can use both of them because we have one target to remove the lesion by embolic resection. So this is the old debate between the old school and maybe this is the recent school, EMR. This is the EMR and this is the ESD. Because I'll take the devil side, I'm EMR, I'm taking all the time about the EMR can remove any lesion. Any lesion can be removed by EMR. As we can see here, this lateral spreading tumor at the hepatic flexure. As you can see here, it's very difficult to position, okay? And we put the patient in the position to keep the gravity on the other side, and we started by injecting the lesion using the regular injector. injecting from the cecal side first, then after back we go to the anal side. Now we use a snare to remove this large lesion, this actual lateral spreading tumor, granular type, mixed nodular. So we start by the large piece, then after that we will see what the remaining of the lesion. We can see this flat part of the lesion. So at time we can change the snare from large caliber snare to another smaller snare and remove the whole lesion, as we can see here, from both sides of the lesion. After that, you can observe here that we change the type of snare to become hexagonal and smaller in size, and remove the whole lesion, as we can see, very nice view. After that, we can use the hot biopsy and pick the bleeding vessels to make sure that we did hemostasis. To make sure that we remove the whole lesion, we use here the APC probe from RB to do APC for all the edges. Then after that, we close the defect.
So it's quite a really good procedure that you have done with the EMR, but actually you don't have margins, so you cannot say that this is a therapeutic resection. So if we are speaking about the target that you have mentioned, that we have to have an in-block resection, we have to proceed for ESD. You can see here this is a submucosal tumor in the antrum of the stomach. When we start with the classic steps of ESD, here we do the marking first, followed by injection. We inject usually a methylene blue, and we inject all the parts of the tumor. Especially in the stomach, we have to do marking. Usually we don't do marking in the colorectal. After that, we bring the knife, our weapon. This is the knife-based resection, and we start doing the circular incision outside the marking. And this helps you to get more and more safety margin. You can see this is the blue color that we love about ESD when we see it. Here is our circular incision, and then here we use the hybrid knife, and we can inject, dissect, and coagulate at the same time. Here's the blue color. You can see the blood vessels in front of your eyes, and you can prophylactically coagulate them. And then afterwards, the lesion, this submucosal tumor, becomes more heavy. It gets to the gravity site, and this gives you like a spontaneous traction. This is the final cut. You can see here the lesion bed looks very nice, and here is the lesion you have resected, and which is really important about this, that the marks are really evident in the specimen. So we have a therapeutic resection. You can say it by your own eyes that you have a therapeutic resection. So you can have a therapeutic resection with the EMR if you have a large lesion, right?
But still, it's difficult, time-consuming and costly. I think EMR is much more easier.
Maybe it's well known. It's not about difficult. It's well known, and about the cost, I think it's worth it, because you will have an R0 resection. Press an R0. You can see this. Yeah.
But if you look to this lesion, also this lesion in sigmoid colon, and you know that it's a very difficult part of during doing ESD, by simple technique like this lateral spreading tumor, you can see it's as simple as we inject also on the cecal side. We can inject on this side, the left side, then on the right side. Even this lesion may be 2 centimeters, I think. You can see this good lifting, both sides. After that, we can catch the lesion in one piece with a snare, as you can see here is. And we make sure that we remove this large lesion in one piece, so we can remove this lesion and also going to the back without any residual in one cut. This will, we can spend just 5 minutes, 10 minutes maximum to remove that large lesion. Also after that, without bleeding, we can close this defect with hemoclips. I think it's much more simple.
Maybe for this kind of lesion, but we can face a lot of situations where EMR is not suitable for the patient. So if you proceed for EMR with any lesion, there's going to be a recurrence. It's not going to be an R0 resection. And as you said in the beginning, our target is the in-block resection. We get more R0 resection, less recurrence, and even no surgery. So if we shift to this patient, this is really a miserable, poor patient. This is a patient of an ulcerative colitis, advanced one, with a laterally spreading tumor with a previous trial of EMR. And you can see here's the sigmoid. It's a sigmoid laterally spreading tumor. It's very, very tough. As you can see, it's not properly lifting. Here we start with a marking, followed by the circular incision. Here we use maybe what we call it the pocket technique, or a modified pocket technique, to get below the lesion. We just perform like a small tunnel below the lesion. Here's the muscle on 12 o'clock and the lesion 6 o'clock, and there's the submucosa, the blue color that we like most. As you can see here, it's really a very tough lesion. I don't think EMR could help in such a situation. And as you can see here, here's like the lesion becomes like a flap. It becomes in the dependent part, and here is you're doing the final cut. You inspect your bed carefully to see if there's a bleeding points, or if there is a muscle injury, or if there is any perforation. And then as you can see again that we have performed ESD with the marks inside, and we have done it with a therapeutic resection. And actually this patient has a high-grade dysplasia and he's been safe from surgery. So therapeutic resection is the goal. It's not about time, it's not about money. This is a tough case, and it's not about cost.
But I think still you have many difficulties, and it's unsafe. You have high risk of bleeding, high risk of perforation.
Yes, but actually it's worth it, and we can deal with the complication, because one of the very important things before you start ESD training, and even in the ESG guidelines, that you have to be an expert in EMR and you can deal with the complications. So it's worth it. You can see this is a very large lesion. It's like a ST in the rectosigmoid lesion. It's one of the biggest lesions that we have removed with multiple tunnel technique, as you can see this. So EMR will not help here. Also, here is another lesion that we shared together, if you remember. This is a rectosigmoid. We have just peeled the whole rectum, or the proximal part of the rectum, with the sigmoid. I don't think EMR could benefit. This is a vellus adenoma with intramucosal cancer, and the patient had a therapeutic resection. So therapeutic resection, EMR will not help in this situation. You need ESD.
And the complication, the bleeding and perforation.
So if we're speaking about the complication, we have to face the complication. First is that you don't panic. This is the persistring technique that we have learned in China to close the defect. This is a perforation. As you can see here, we just clip the endoloop at the edges of the perforation. So you have to have a very good assistant to help you with this. And then afterwards, we have dislodged the endoloop. You have to recatch the endoloop again and gently close the endoloop with the clip upright. And after that, you can see we have closed it. And of course, we have much modern techniques like the endo stitch, and there are a lot of closure devices right now. So what about bleeding? This is one of the most horrible bleedings that we have during an ESD procedure. We thought that it's an internal iliac artery. However, we tried to catch this blood vessel. It's a big blood vessel. We have tried to catch it many times with a coag grasper. And actually we thought it's working, but actually it's not working, because the mouth of the blood vessel itself is larger than the largest coagulation forceps. So we have shifted to a hot biopsy forceps. Of course, it's not our preferable, but maybe it's larger a little bit, but actually it did not work also. We are trying hardly to stop the bleeding. So what we will do, we will manage. We try to get an injector, inject adrenaline, ask the anesthesia doctor to lower the blood pressure for you, and then things are becoming a little bit more calm, and then we re-inject again with adrenaline. So it seems horrible, but the very first message that we want to tell about this is that you don't panic, okay? And then afterwards, here, as you can see here, the bleeding starts to vanish, and you do more and more coagulation. And then still a little bit of oozing, as you can see here, it's a little bit oozing. It was a huge spurter, and it ends like oozing, so you can control it right now, and you can catch the whole blood vessel. And afterwards, you have to do full hemostasis to the bed, full hemostasis, as you can see here, but actually you did not need surgery in this patient. You don't need intervention radiology to stop the bleeding for you. You continue with your procedure. As you can see, here is our bed. And then, as you can see, this black hole, this is a very large blood vessel. This was a feeding vessel to this tumor. And we coagulate more and more and more. And then at the end of the procedure, we prefer that we put a clip on. You can see this is the big mouth of the blood vessel. We could manage it. But this is not the routine. This is not what we usually have during the ESD. This is one of the most difficult bleedings that we have experienced, but this is not the usual. But even if it is controllable, we have done like 800 cases of third space till now in Egypt and endoscopic resection, and we did not, and ESD, sorry, and we did not have to send a case to the surgery because of the bleeding or even because of the perforation. So it's a matter of experience. It's a matter of that you put to yourself a plan and a strategy how to proceed and how to control if you have a complication.
But I think EMR is still much more easy.
And you can see here at the end, we put a clip on the mouth of the blood vessel so it won't re-bleed again.
Very tough mission, but challenging.
Yes, it's worth it. So speaking about EMR and ESD, sometimes you can combine both, as you can see, I've seen with Dr. Pradeep today. So for you not to be mad at me, we have combined the hybrid EMR and ESD. This is a lateral spreading tumor in the cecum. It's recurrent after EMR. And we started with the classic steps like doing injection. Then afterwards doing a circular incision. As you can see here, we move with a circular incision. You see the blue color that we love the most is the blue color. Okay, because doing ESD in the cecum is really tough, but we think the lesion or the recurrent part of the lesion is small and the lifting is not that bad. And we start to go on all around the lesion, all around. This is the cecal side of the lesion here. And afterwards, then we decided to change our strategy. So why to go on with ESD classic while we can catch the whole part with a snare? So it's not about ESD, it's not about EMR, it's about in-block resection. So you can save your time and your money and less complication as you wish. Is this good for you?
Yeah, so the snare finished the mission.
Yes.
So our message, we are not competitors, we are complementary, we have one goal, in-block resection. Finally, we need to announce about our fourth wave of CAPIC courses, Kasr al-Aini, ESD and third space endoscopy basic course. It will be held in Learning Resource Complex in Cairo University at next 12 and 13 of October. This is our team, and thank you.
Thank you, doctors. We have two questions from the audience. So the first one is, after EMR resection, do you always use coagulation current for margin management?
You mean, yes, actually we don't do piecemeal EMR anymore, but if we have done piecemeal EMR to a tumor that we are sure by endoscopic diagnosis that it's not a cancer, it's not invasive or even no intramucosal cancer or high-grade dysplasia, it's better that we do argon, APC, or maybe sometimes we do a coagulation to the edges and to the bed so that if there is any residual small part that we have to like kill it before it comes back again.
Another question from the audience. If we did piecemeal EMR for a lesion suspected to have high-grade dysplasia, do you agree or not?
Agree about? I didn't.
Piecemeal EMR to lesions on suspected high-grade dysplasia.
No, actually, I think this is the same question and the same answer. We don't prefer to do piecemeal EMR specifically for lesion like high-grade dysplasia lesion or even intramucosal cancer. We prefer to remove the lesion en bloc by ESD. because a dedicated pathologist will tell us about the R0 section, what about the horizontal and the vertical margin. He will assess exactly the layering and the depth of the invasion, whatever it's high-grade dysplasia, or even reaching up to the whole width or the whole depth of the mucosa. So our answer, I think, me and Shaiman agree about, we no more piecemeal MR for us, at least our team. We prefer ESD because this will give you the R0 section much more higher than the piecemeal MR.
Thank you.
Thank you.